Hey everyone, thanks for making the time. Today we're going to talk about postoperative hiccups. It doesn't get discussed very much, but it came up in a real patient conversation recently, and it's worth 10 minutes of our time. So here's the story. A patient we cared for called our office a few weeks after his surgery. He wasn't upset, he wasn't complaining, he was curious and a little worried. He told us he'd had hiccups for days after his most recent surgery with another group. Really persistent, disruptive hiccups that lasted for 4 days. But he did not have them a few months earlier when one of our clinicians cared for him. Same patient, two similar anesthetics, just a few months apart. One resulted in postoperative hiccups, the other didn't. He wanted to know what was different. And because he'd been reading online, he also wanted to know if a friend was right that hiccups after surgery can kill you. So, what did change between the two anesthetics? And is he right to be worried? That's what we're going to work through today. So, quick foundation. A hiccup is an involuntary spasm of the diaphragm followed by abrupt glottic closure. The hic sound is your vocal cord slamming shut a fraction of a second after the diaphragm fires. It's a coordinated reflex, not just a twitch. Duration matters clinically. Under 48 hours is usually considered acute, self-limited, benign. Between 48 hours and a month, we call that persistent. And now we're thinking about doing a workup and maybe treatment. If they last over a month, they're intractable and rare. So here's the anatomy and explains why the OR is such a hiccup-inducing environment. 3 parts. On the left is the afferent limb, sensory input from the phrenic, vagus, and sympathetic chain. The middle of the picture is the central modulation at the midbrain hiccup center. On the right, the efferent limb, motor output back to the diaphragm and intercostals. Here's the key point. Any irritation along that arc can trigger a hiccup, and in the OR, we touch every single point on it. Airway and gastric distension on the afferent side, anesthetic agents and metabolic changes centrally, surgical stimulation and phrenic irritation on the efferent side, which brings us to our triggers. So the 4 buckets frequently coexist. Pharmacological, anesthetic agents, steroids, benzos, which we'll come back to more in a bit. Airway and procedural, intubation, gastric distension from mask ventilation, central line placement, especially in the IJ or subclavian. Surgical, thoracic, and upper abdominal cases carry the highest risk. And metabolic and patient-related. Electrolyte disturbances, hypocapnia, GERD, far more common in male than females, which is the most consistent patient risk factor in the literature. Our patients often get 3 or 4 of these stacked in a single case. Surgery and anesthesia are inherently high risk. So, how do we treat it? 2 things to reach for first. On the left is physical maneuvers. Don't skip past these. They're free, they're safe, and sometimes they work. Breath hold with Valsalva, cold water swallowing, pulling knees to the chest. You're either stimulating the vagus or interrupting the diaphragmatic rhythm. In PACU or on the phone with a patient, always start here. If the hiccups persist, Reglan, 10 milligrams IV, has a high effective rate and is readily available. RCT supported, on the cart, addresses gastric distension, which is one of the mechanisms we've likely contributed to intraoperatively. In the only randomized trial for persistent hiccups, Reglan has a 65% efficacy rate versus 24% with the placebo. So it's a strong first move. Here's the whole picture in one view, stratified by clinical scenario. Step 1, intraoperative or immediate. Reglan 10 milligrams IV, plus or minus an OG or NG to decompress the stomach if you haven't already. Step 2, refractory intraop, lidocaine, 1 to 1.5 milligrams per kilo IV bolus. It's universally available, we already use it, and there's emerging evidence for its use in hiccups. Step 3, if they persist beyond 48 hours, oral baclofen 5 to 10 milligrams 3 times a day. Alternatively, you can use gabapentin, especially if you believe it to be CNS-related hiccups. Step 4, intractable. This is the ones lasting like more than a month. Interventional, stellate ganglion blocks, phrenic nerve blocks, or sometimes using them together, ultrasound-guided nerve block technique. It works. There's case report evidence only, but it's out there. And notice the orange highlight. At any stage, if you suspect dexamethasone is the trigger, do not use it and rotate the steroid. You can use methylprednisolone instead. This is the practical divide I want you to internalize. On the left, what we immediately have available to us in the OR. All IV. Reglan and lidocaine are your two true treatments here, and they actually act on the hiccup reflex. Metoclopramide is the first move, lidocaine for refractory cases. Methylprednisolone is a little different, and it's worth being precise about why. It doesn't treat hiccups. It doesn't touch the reflex at all. What it does is remove a potential trigger. So if you suspect Decadron caused the hiccups, you rotate to methylprednisolone. It keeps the same antiemetic and anti-inflammatory effect that you wanted, and the hiccups resolve because you've taken away the cause. The data does back this up. When they gave dexamethasone back, the hiccups came right back in about 3/4 of patients. But if something else is the culprit, midazolam, gastric distension, the surgery itself, rotating the steroid won't help because dex was never the problem. Chlorpromazine gets a use with caution flag because of hypotension. So if you're going to use it, preload fluids, use it short-term, acute use only. On the right are the oral maintenance options, baclofen and gabapentin. These are for the 40-hour plus story, not the intra-op moment. The bottom line, metoclopramide and lidocaine treat, methylprednisolone removes a potential trigger, and all three are options you have right in front of you. So let's make this practical. A patient tells you, or their chart tells you, that they had bad hiccups after a previous surgery. What do you actually do differently next time? Well, you should make 4 adjustments. First, avoid midazolam. It has the highest reporting odds ratio for hiccups of any anesthetic drug, and it is dose related. If you can skip the benzopremed, skip it. Second, rotate the steroid. Give methylprednisolone instead. Dexamethasone 10 milligrams is roughly equal to 50 milligrams of methylpred. You keep the antiemetic and anti-inflammatory effect, and it's RCT supported. Rotate, don't remove steroids altogether. Third, treat the patient with metoclopramide 10 milligrams IV at induction. It's on the cart, it's RCT supported, and it doubles as PONV prophylaxis. And fourth, mind that gastric distension directly. Gentle mask ventilation, watch your peak pressures, consider decompressing the stomach early. And a couple more to keep in your back pocket. Maintain normal capnia and consider regional if the case allows. One honest caveat. In any single patient, this is association, not proven causation. But the pattern is real. It costs you nothing to act on it, and reassurance comes first. These hiccups are common and are almost always self-limited. Okay, so back to our patient that I spoke to on the phone. We compared both anesthetic records line by line. Both were general anesthetics with an LMA. Both were knee scopes, similar induction, similar maintenance. There was exactly one meaningful difference between the two anesthetics. Midazolam. He didn't get it with us. He did get it with the other group. And the evidence backs it up. Midazolam has a 3.9% incidence of hiccups in adults. It's dose-related. 2 milligrams causes more than 1 milligram. And in FDA adverse event data, midazolam has the highest reporting odds ratio for hiccups of any anesthetic drug. We can't prove causation in one patient, but the pattern is real. So what did we tell the patient? We told him to tell your next anesthesia team that you have a history of postoperative hiccups and ask them to avoid midazolam because you believe that was the culprit. And on his other worry, no, hiccups after surgery are not going to kill you. They are common and almost always self-limited. And there are medications and interventions that we can use to treat them effectively. 3 takeaways for today. Post-operative hiccups are common and rarely dangerous. Reassure the patient first. The internet has scared a lot of them. Midazolam and dexamethasone are the 2 drugs to think about. For patients with a history of post-operative hiccups, consider skipping the benzopremed, and if steroids are the suspect, rotate dex to methylprednisolone rather than dropping steroid coverage altogether. Reglan 10 milligrams IV is your on-the-cart first move. Escalate to lidocaine if that doesn't work, and then of course there are oral agents that you can use if it persists. And that's it. Thanks for listening. Happy to take any questions via email, and have a great day. Thanks for your time.